Hi guys, welcome to 10-Minute Medicine and this video on seeing someone in pain post-operatively. This is a common bleep you'll get on surgical on-calls, so I hope this makes you feel more prepared. When seeing someone in pain, always assess it using tools like Socrates, site onset, character radiation, associated features, the timing of the pain, exacerbating features, and severity. This will help you characterize what sort of pain it is and what you need to do next. Objective assessments of pain would be looking at the OBS of that patient to let you know how well they are or whether they're deteriorating, looking at the op note to know exactly what operation they've had, and examining the patient, including specifics to the operation. It's important to always assess for underlying pathology when reviewing someone in pain post-operatively. Don't just assume it's because of the operation. Take a look at these scenarios and think about what they could mean in a post-op patient. So think about someone you're seeing on the orthopedic ward where the nurse has bleeped you that they're in pain. You go to see them and they have severe and progressive leg pain post this orthopedic surgery, which worsens when they're passively moving their ankle. Next, you're bleeped to see someone with abdominal pain post-abdominal surgery. They've got pain, distension, and are vomiting profusely. You can't hear bowel sounds. Someone else that's also had an abdominal operation, the nurse bleeps you to tell you they're in pain. The pain's actually in their leg. It's unilateral and they've got swelling in that leg. And finally, someone's tachycardic and has a fever post-GI surgery. So I'll give you a moment to think about these and pause the video if you want to think about them some more. So I've written here the few things that I was hoping you would think about in these presentations post-op. Don't worry, they definitely come with practice spotting these signs, and with the whole clinical picture it's a lot easier. But I was hoping you'd think of compartment syndrome, ileus or bowel obstruction, a DVT or an anastomotic leak. So the main takeaway is always review the patient clinically with a full A to E assessment and escalate to a senior if you're unsure. Before prescribing pain relief, I like to check these things. Check their renal function, check their liver function, look at what allergies they have, how much do they weigh, and think about other contraindications. For example, are they a particularly frail patient or are they on anticoagulation? Then I go to prescribe my pain medication using the WHO pain ladder. The first step of that ladder would be using paracetamol and NSAIDs. Then we move on to weak opioids like codeine, dihydrocodeine or tramadol. And then if it's severe pain that isn't responding to those first two, then we think about morphine or oxycodone. Afterwards, it's really important to reassess the patient after 12 to 24 hours. Have they improved? If they're worsening, seek advice from an anaesthetist or your surgical seniors. You might also have chosen to do this earlier on in your assessment. Treat side effects, for example, constipation or nausea, which are very common from painkillers. Always switch from regular to PRN if the pain is improving. And always involve the patient in the plan and communicate clearly what you're doing. So next, I'm just going to go through these different modes of pain relief and some things you have to consider for each one. Sorry if it's dry, just take pictures of what you learn and come back to it when you're going to prescribe these medications. Paracetamol is usually safe to use in renal impairment, but you'd consider reducing the dose in hepatic impairment. If someone weighs less than 50 kilos, which does happen in hospital in frail ladies and young people, or children of course, reduce dose to 15 mg per kilo per 24 hours. Cautions include heavy alcohol history, G6PD deficiency, acute liver disease, and often a patient will come into hospital already taking cocodamol or codridamol, which actually have paracetamol in them. And if you prescribe paracetamol, as well as this, then they'll have an overdose. So make sure to cross off those compound preparations and prescribe their composites differently. NSAIDs, for example, ibuprofen, naproxen, diclofenac, avoid them in renal impairment, caution in hepatic impairment. Of course, there are lots of side effects here: gastric irritation, reduced renal function, prolonged bleeding times, and bronchospasm. We like to avoid these in hospital because of the risk of GI bleeding, but sometimes they have a place, and I would always discuss NSAIDs with a senior actually because of that risk. Cautions would be in the elderly, because your renal function reduces with age, if you're dehydrated, if you have low urine output, if you're on other nephrotoxic drugs, and if you're at risk of non-union with a fracture or poor bone healing. Co-prescription, so with NSAIDs, I always consider a PPI to cover if NSAIDs are given regularly to protect the lining of the stomach. Codeine, so I've written here some doses that you can consider for elderly or frail people as well. Avoid them in renal and hepatic impairment. Side effects include constipation and nausea, so that links to these co-prescriptions, which are laxatives and antiemetics. Contraindications would be if someone is breastfeeding, and caution in the elderly. Did you know that 10% of codeine is metabolized to morphine? However, in 10% of the UK population, it isn't at all. So people will not respond to codeine and not get effective pain relief from it. You may find that those are your patients, so it's worth speaking to a senior about which other pain relief you could use in this instance. Tramadol is more and more being used. It's good to know about it. For renal impairment, we would prefer tramadol in this instance. Some side effects include drowsiness, nausea, and dizziness. Contraindications to tramadol would be epilepsy or any history of seizures. A decreased seizure threshold is caused by tramadol, so I would be extremely cautious about it and speak to a senior if you're considering it in someone with head injury, intracranial lesions, raised intracranial pressure, or postcraniotomy, so in a neurosurgical context. Finally, onto morphine. So these are the doses. I would always halve the usual dose in an elderly or frail person. Note these are the oral doses for Oramorph. IV morphine is basically never prescribed by an F1 and is only safe to give in certain areas of the hospital. So make sure you're prescribing it orally if you are, and check with your seniors if you're unsure about that prescription. Here I've just written about renal impairment, about how I reduce doses in that case. Take care if someone's EGFR is below 30. That rings alarm bells for lots of medications, and morphine is one of them. Hepatic impairment also, you would use it cautiously, and if they have a low weight, which makes sense. Cautions include if they've used opioids before, check their drug chart, what have they come in with, check the history with the patient, are they already using other opiates, are they frail, have they got bowel obstruction, or are they hypotensive, then I wouldn't as quickly prescribe morphine. Always prescribe naloxone PRN to reverse it, and say to the nurses if they're drowsy, I've got a respiratory rate below 12, give that naloxone, and always prescribe antiemetics and laxatives as well. Side effects of morphine include nausea, itching, constipation, and respiratory depression. Oxycodone is an alternative to morphine. It's half the dose that you would use for morphine, 2 to 4 hourly PRN, and half the dose again if someone's frail or elderly or opioid sensitive. Again, here's how to reduce that dose for renal impairment, and it's pretty similar in terms of side effect profile to morphine. Sometimes it's better tolerated than morphine if morphine causes excess sedation, nausea, or hallucinations. So,